is, actually the name is already in the abstract, but I'm not sure that all the spelling are correct. So I make sure again that here is the correct one. Those people who are investigate, you can see your name there. All right, so that's 7 countries that we can manage to work in that timeline that we set. All right, so the question was that what information are important for decision making of the participants, okay? So we carry out a multi-center cross-sectional descriptive survey to determine participants' preferred information in the ICF. We worked this through the questionnaires. The questionnaires was developed and validated by a Fercap expert in different areas. Seeker item was 37 items in 6 pages. It's following, the ICH-GCP, Declaration of Helsinki, and CFR 46. Okay, so the data was collected as anonymous, self-administered, structured, paper-based questionnaires. Okay, the site include India, Indonesia, Malaysia, Philippines, Sri Lanka, Taiwan, and Thailand. The study populations were the research participants in biomedical research. I have to emphasize it in biomedical research only, because if you are doing the social behavioral science, it could be different things that they want to know. So we decided to separate these 2 studies. Okay, so the duration of the study was 3 months, during June to August 2007, which is last year. The example of the questionnaires that we use, we look at the level of importance. We look at all the elements essential that required by the regulations. Okay, this is an example, one of them, like title of research, name of researcher, blah blah blah. So we put into 5 the scales of 5, which is not important, slightly important, moderate important, fairly, and very important. So the number that we gave is 1 to 5, 5 being very important. Okay, and besides that elements, we also have the section on the comments that, okay, how many pages of your preference? As well as if you have additional things that you want to know, so they can list it down. What else that they want to know beside all these things? Right, so the result of this came out that there's 54 study sites in 7 countries. Okay, there were 2,113 questionnaire returned out of the 2,484 given to the participants. Majority of respondents say that, you know, more or less male and female are the same, because 57, 50, not that much difference. So most of them are middle-aged adults, because we select the research participant in adult. We didn't take any research in children. So the result is that those elements that we have that from the guidelines and the regulations, it's the same as what they want to know. Of course, the level of what they want to know and not important, the level of importance is all those data are being analyzed right now, because it's a lot of data that we have to deal with, and also with different countries we have to look at, because we look at the cultural aspect as well. So that's why I don't have that result for you yet, but the result will be presented in the next meeting. But it's going to be published probably before the next year. Anyway, so the mean score of that's important is rated as moderate, important or higher, which is 4 or 5. So the mean score is range from 3.58 to 4.47. Okay, so there were 54 additional comments, which we are analyzing it now as well, that what else that they want to know. Okay, so this study is the largest empirical study to suggest that, or to confirm that actually, because we've been complaining all the time, regulation wants this and that, whether they really want to know. So at least this study is the study that will confirm that those elements that have been listed by the regulators, the participants also want to know, but they may want to know something else, which we'll add that next year. Okay, so the participant preferred information are in line with those required by the ethical and regulatory guidelines. With that, at the moment, the current status is that we are working on the association and levels of importance of each element in informed consent form in different groups of participants are being analyzed right now. I would like to acknowledge many more people, 100 investigators, but we have more people who are supporting this study, collecting the paper and all sorts of things. So with that, thank you very much.
Thank you so much. If we have any questions in the audience, we'll hold them till the end of the entire set of presentations, if that is agreeable. Thank you so much. Wonderful presentation. Give her another hand. And I now request Anand to invite our next speaker.
Our next speaker is Professor Nitya Gogte, and she'll be speaking on the use of deception in dental surgery research.
Good morning, everybody. Respected chairpersons, ladies and gentlemen. Deception in clinical research is said to occur when investigators communicate deliberately in a way that produces false beliefs. There are two ways in which deception in clinical research can be done. One is to provide participants with false information. The second is to withhold information. Let's understand deception with an example of a study on experimentally induced pain. When patients with pain were told that a painkiller was being given, when actually normal saline was being given, they experienced pain relief. And when they were actually given a painkiller infusion and told that the infusion had stopped, the pain recurred, but the infusion had not actually stopped. So the important question is, what is it that drives response in an intervention, and therefore why deception is needed in clinical research? The first thing is the effect of the intervention itself. But perhaps another more important point is the expectation of the participant that the intervention will actually work. Therefore, expectancy essentially forms the core of the practice of deception in clinical research, and what deception researchers do is something called as expectancy manipulation. So the question now is, do means justify the end? And you have proponents of deception and you have opponents of deception. So the opponents of deception say that deception impacts a fundamental ethical premise, and that is autonomy. So you don't have the chance to say no, whereas the proponents say that you must use deception because that's the only way that you'll arrive at the end. And therefore, the opponents of deception state that you could use authorized deception. In other words, tell the participants that they are being deceived, something that is mentioned in the ICMR 2017 guidelines. And therefore, the present study was carried out to assess the use of deception in dental research, and because we couldn't tell the participants that they were being deceived, the title of the study was Evaluation of the Impact of Cost on the Response to a Painkiller in the Management of Dental Pain After Third Molar Extraction. The primary objective was to evaluate if there was any difference between authorized and non-authorized deception, and the secondary objective was to assess if knowledge of the cost of the painkiller actually impacted the response to it. To give you an overview of the study, participants needing surgery for an impacted third molar were divided into two groups, the authorized deception group and the non-authorized deception group. Subsequently, they were divided into two groups. They were told that they were either getting an inexpensive painkiller or they were getting an expensive painkiller. So the deception in the process was that all participants actually received the same painkiller, which was the standard of care, except that they were told that they were either getting an inexpensive painkiller or an expensive painkiller, which was labeled on the envelope given to them. The study protocol was approved by the Institutional Ethics Committee, and because we had two different and diverse and disparate groups, we had two different consent forms that were approved by the IEC. In the authorized deception, it was stated that you will be deceived in some way. We will not, however, be able to tell you how you have been deceived. But please note that this is needed for the very purpose of the study. The treatment that you are getting is standard of care. The study has been approved by the Institutional Ethics Committee, which is safeguarding your rights and safety, and we will tell you at the end of the study in a process of debriefing as to how you were deceived in the study. The non-authorized deception group had a standard consent form. Because they were first level and second level, we needed 2 sets of randomization, which was generated from www.randomization.com. So the first level randomized them to authorized and non-authorized deception, and this was known only to the PI and the co-I. And the second level was visible to everybody, so the investigator as well as the participant, and we concealed allocation up until the point of randomization by using sequentially numbered, sealed, opaque envelopes. So when the participant opened the envelope, he or she would realize whether it was an inexpensive painkiller or an expensive painkiller. So what we wanted to prove was the alternative hypothesis, in other words, that the authorized deception is similar or equivalent to the non-authorized deception. Why did we use the third molar extraction model? Because the US FDA has approved this as the model of choice to evaluate analgesic efficacy. We included adult patients who needed surgery for a third molar extraction and excluded those with hypersensitivity to NSAIDs, a past history of coagulation disorders, as well as those on antiplatelet therapy. The standard of care given to the participants was a combination of diclofenac plus paracetamol twice a day for 3 days, both drugs coming from the same batch and the same manufacturer, the only difference being the labeling. Concomitant therapy was amoxicillin plus clavulanic acid, and we permitted tramadol 50 milligrams as rescue medication. The primary outcome measure of the study was pain that was recorded on a visual analog scale with 0, no pain, and 10, which would reflect extreme pain. The VAS was done every 6 hours, and the patients were asked to follow up the next day. The secondary outcome measures was the proportion of patients who took rescue medication, as also the duration of surgery and the mouth opening, and structured debriefing was done at the next day when the patients followed up. We calculated the sample size based on the visual analog score, and this was a sample size for equivalence, where we assumed a margin of 1 for equivalence, a standard deviation of 2, and assume a 20% consent withdrawal or an attrition. We plan to enroll a total of 220 participants. Both descriptive and inferential statistics were done. Quantitative data expressed as median and range, categorical data as proportions. We did both a within as well as a between group comparison, wherein we use ANOVA and linear regression for the VAS and the peak pain score, whereas the rescue medication was analyzed using the Fisher's exact test. Debriefing was a qualitative analysis, and all analysis were done at 5% significance using the GraphPad Instat version 3.06. The trial was prospectively registered with the Clinical Trials Registry of India. If you look at the results of the study, we enrolled a total of 222 patients. A large majority of the patients were female. The duration of the surgery on an average was 25 minutes. We had 3 dropouts or protocol deviations, just 1 consent refusal. 112 patients went into the authorized deception and 105 into the non-authorized deception group, and we had 219 patients for the per protocol analysis. When we did a between group analysis of authorized versus non-authorized deception on the VAS score, we found that there was no significant difference between the 2 groups. Neither was there a significant difference in the peak pain score. We also did a within group analysis of expensive versus inexpensive painkiller, both for the authorized deception as well as the non-authorized deception, and again there was no significant difference in the pain scores. The secondary endpoint was the rescue medication, authorized versus non-authorized. Again, lack of a significant difference in terms of rescue medication taken by the 2 groups. We then did a within group analysis of the rescue medication. If you look at the non-authorized deception group, there was no significant difference between the expensive and the inexpensive medication. However, when you go to the authorized deception group and you looked at the within group analysis of rescue medication, only 12% who received the so-called inexpensive painkiller took rescue medication. However, 30% of those who took the expensive painkiller took rescue medication, and this difference was statistically significant. The structured debriefing elicited mixed responses. The authorized deception group felt that, good, you told us that we were being deceived. However, there were also participants who said that it doesn't matter, we have faith in the doctor, and in any case we were told that we were receiving standard of care, so it didn't matter whether you deceived us or you didn't deceive us. The present study is unique in that it adds to the existing body of evidence on authorized versus non-authorized deception. There's exactly one study comparing in a randomized fashion authorized versus non-authorized deception in literature. Our study conforms to that study in that there is no difference, at least in this model of third molar extraction, based on the outcome measure of visual analog scale. So this study by Martin and colleagues was experimentally induced pain and using a painkiller versus a regular moisturizer, and the study found a lack of difference between authorized and non-authorized deception, suggesting that authorized deception may be an acceptable modality of deception. However, the difference between our study and that study was, if you looked at our authorized deception group, 12% only within the authorized deception group took rescue medication against 31% in the expensive medication group. And we felt at the end of the study that authorized deception may in some way actually affect expectancy and may not be truly sterile. The limitations of the study were that although we had a structured debriefing, we did not ask the opinion of research of the participants about researchers who do deception research. And we could have looked at the profile of the mood states because deception is believed to be an emotion-inducing state. To conclude, authorized deception versus non-authorized deception in a randomized controlled equivalence trial on third molar extraction are equivalent. However, given the difference within the authorized deception group in terms of rescue medication and not the VAS score, this modality of deception needs further exploration to see if in some way it impacts the very core of deception, and that is expectancy. Thank you, ladies and gentlemen, for your kind attention.
Thank you so much, Dr. Nitya. A wonderful study. Again, we'll take up questions at the end of the entire session. With that, may I now invite Dr. Henry Silverman. He'll be speaking on the perspectives of Myanmar research towards informed consent forms, practices, on behalf of Khain Zhao, who has been listed in your program. Take it away, Henry.
Thank you, Chair, people and audience, for allowing me to give this presentation entitled Perspectives of Myanmar Researchers Towards Concepts and Practices in Informed Consent. The lead investigator, Khain Zhao, obviously, I am not Khain Zhao. It is unfortunate that he could not make the trip. This was a qualitative study, and people who do qualitative studies know how exhausting it is to analyze the transcripts. And in the last week, Khain Zhao and I analyzed the last two transcripts of this study, and what could I say? It just completely knocked them out to the point where he could not make this trip. So I am proud and honored to do this presentation for him. So, background and objectives. The increase in health research in Myanmar has enhanced the importance of informed consent practices among researchers, and hence the objective of this research was to assess the perspectives of Myanmar researchers toward concepts and practices in informed consent, and also to determine cultural influences on informed consent practices in Myanmar. Our methods was a semi-structured, in-depth interview study. We had a convenient sample of researchers from research institutions in Myanmar, and this presentation will show the results of 5 participants. We had a semi-structured interviewed guide that had these questions in the interviewed guide. Regards our interview, we conducted, or Khain Zor-U conducted face-to-face interviews conducted in Burmese, which were audio recorded and then transcribed into English, and Khain Zor-U checked the translation for accuracy. Both Khain Zor-U and myself independently analyzed the interviews. We generated the initial codes, identified and named relevant themes and sub-themes, and reached consensus on these themes. This slide shows the major themes that we identified, and it included the purposes of informed consent, types of information that should be disclosed in the informed consent, aspects of the informed consent process. Another theme included that participants are concerned about privacy and confidentiality. We identified several cultural aspects of informed consent. We identified several challenges to informed consent, and we also identified some informed consent practices by the investigators. So, regarding the theme of purpose of obtaining informed consent, we identified several sub-themes that included respect for persons, autonomy, voluntariness, importance of rights, the right to withdraw without penalty, right to privacy, and the importance of informed consent in order to publish. I'd like to show a few quotes regarding these sub-themes: respect for persons, informed consents, and these are the narratives from the participants in this study. Informed consents are comprehensively important because everyone has its own right to know. Autonomy related to research. They have freedom. They can decide whether they participate or not freely. Voluntariness, whether they participate or not, let them know that the hospital will continue giving them treatment or benefits they are getting now without being influenced by their participation in the study. Only by then they can participate freely. Right to withdraw, they must know if they decided to withdraw, they can do it anytime. We need to accept the patient's right to voluntarily quit from participation in the research. We cannot bind them to research without their consent. Privacy rights, If your study included information which needed to be explained, or if sensitive issues are involved, the subjects are explained one by one, since privacy is very important in research. We explained everything about our research in a private room, in a clinic, and they said yes next time. Regarding the theme of types of information to disclose, we had the sub-themes of advancement of science, purpose of research, and the importance of describing the procedures. In the interest of time, well, let me show this quote. Sometimes they would ask, well, why they are selected, although there are many other patients in the hospital. They might suspect about something. Those parents from selected child might also worry and suspect why their child was being asked. Is he worse than the other, or something like that? That is why we need to explain why they had been invited to participate in the study. The theme regarding the informed consent process had sub-themes of the information needs to be understandable, there needs to be time to ask questions, and the sub-theme of a two-tiered process for obtaining informed consent. Regards to time to ask questions, we must give them time for feedback questions. The aim is to ask about it to us at any time. There were cultural aspects regarding the role of women, literacy in rural areas, and also the recruitment process in rural areas. Regarding the role of women, women are more dominant in our country. I did not know that. For women, as a mother, to give consent on behalf of their child, it is the same. It never happened that they wanted to consult with the family or their husband. Challenges to informed consent included that participants are not aware that informed consent is necessary. They had lack of knowledge of their rights. Lay people are sometimes reluctant to sign. Sometimes the duration of studies would put people off. Myanmar people sometimes expect benefits for being in research, and then there are some recruitment issues. Well, let me skip this. And then we had the theme, informed consent practices by researchers, sub-themes. Sometimes investigators lack knowledge about ethics. There were concern about disclosure of risks, and also there was the sub-theme that Myanmar has to determine their own norms for research ethics. In regards to informed consent practices by investigators, you assume that if you include such risks in your written informed consent, the patients, that is, the participants, will not join the research, and hence one would intentionally leave out the risks. So, limitations to this study included that this was self-report, and the question remains whether with a sample of 5, whether we reach saturation. And also, this study obtained the viewpoints of one group of stakeholders, meaning the researchers. It would be nice to obtain the viewpoints of the participants. So, in conclusion, several major themes were identified. One, the value of informed consent as respecting the right to make a voluntary decision, including the right to withdraw, the importance of privacy. Cultural aspects were identified that needs to be considered. Several challenges were mentioned that needs to be addressed, and several suboptimal informed consent practices were mentioned. Future steps: further qualitative research should be done. We need to enhance research ethics for investigators. We need to enhance the awareness of the importance of research for the Myanmar population, and we need to develop research ethics guidelines that are culturally relevant to the Myanmar people. Let me end by saying that in the next slide, you will see that with a good Burmese meal, we see Kine is readily able to participate in the analysis of this study, and I want everyone here to give a round of applause for Kine Zor-U, who could not be here today. Thank you very much.
Thank you, Henry. So for most of us who are external to Myanmar, I think the face of Myanmar has always been Aung San Suu Kyi, but it's nice to know from your research that most women in Myanmar seem to be occupying leadership spaces in the personal and professional realms. So thank you for your presentation. Also to just say thanks to Henry and BB's program, I think we have close to 20 colleagues who are participating in this conference, and that's great to see, and we hope to see more participation and hopefully a future FERCap meeting in Myanmar.
Thank you very much.
Thank you, Henry.
May I now call upon Dr. Ching Shan Lee from the Ministry of Health, Malaysia, and he'll be talking about payment trends provided to health and healthy and non-healthy subjects. I'm so sorry. Yes, Dr. Shin, take it away.
Right, a very good morning. I would like to wish all, and I would like to send a special thanks to the organizing committee for giving me this opportunity to present my paper. So my name is Shanli Ching, and I am a member of the Medical Research Ethics Committee of Ministry of Health. By profession, I'm a registered pharmacist, and the topic of my presentation today will be payment trends provided to healthy and non-healthy research participants in Malaysia. So before I proceed, I would like to acknowledge my team members, Dr. Peter, Dr. Chang, and Dr. Ho, because without their help, the research would not have been finished. Right, so I would like to give a brief background of the ECs in Malaysia. So basically, we have 13 independent ethics committee in Malaysia that is being recognized by our National Pharmaceutical Regulatory Agency, out of which MREC is the largest ethics committee in Malaysia. So we are central IEC under the Ministry of Health. Basically, we look at protocols that is or research that are being done, carried out in public hospitals within the facilities of Ministry of Health facilities. And we were established in 2002. So our purpose is to safeguard the rights, safety, and well-being of all trial participants. Right, just to give a very brief overview of our burden, this is the number of high-risk studies that is being approved by MREC from the year 2011 to 2016, out of which last year we had a total of 206 research studies, high-risk studies. So I'll just move on to the introduction. So if you look at what was being recommended by AIIMS under the Guideline 13 for reimbursement and compensation for research participants, it says that regardless of observational or interventional studies, participants should not have to pay for making a contribution to the social good of research, and therefore they must be reasonably reimbursed. So they also must be appropriately compensated for the time spent and other inconveniences resulting from study participation. The amount should be proportional to the time spent and also the travel to the research site, and it should be calculated using the minimum hourly wage in a region or country as a reference value. So when you look into detail at what was being recommended for reimbursement, it should be a cost directly incurred during the research, such as travel costs, compensated reasonably for their inconvenience and time spent. And when you look at compensation, it can be monetary or non-monetary, and it must not be so large as to induce potential participants. And it is not meant to compensate for risk, but it is rather meant to compensate for inconvenience and time. So basically, I think during our high risk full board meetings that we have when we look and discuss about high risk studies, we realize that every time when we come to this crossroads of issues regarding reimbursement and compensations, we do not have a figure, what is enough and what is not enough. So we realize that there is actually a lack of clear statements of payment purposes and also a standardized method to actually determine what is the acceptable amounts. And hence, which led us to the idea of actually doing a very brief study to study the disclosure of payment in PIS offered in Malaysia, looking specifically into identifying whether reimbursement and compensation was addressed in PIS, and also to see with regards to studies involving healthy and non-healthy participants. So, the whole of 2016, we had about 1,800 studies that was sent to us, out of which 206 were high-risk studies, which we took all. And we look at it and we divided. It's a retrospective cross-sectional study, and the sampling duration was January to December 2016. So this was the results that we obtained. When you look at the trend for reimbursement, about a third of the study actually addressed reimbursement, a quarter, while a third actually addressed compensation, where only a small number, which is roughly about 10%, actually had both reimbursement and compensation addressed in their PIS. ISR studies has a higher quality in that they address more of it in their studies. And if you look in more detail for reimbursement, we see that out of this 59 PIS that addressed reimbursement, 10% out of it was actually studies pertaining to healthy volunteers. And out of this 59 PISs, only 73% had an actual breakdown on what exactly was being given, what was exactly was being reimbursed, of which traveling was the highest. For compensation, on the other hand, a third of the 206 PISs looked at addressed compensation, out of which only 12% had a breakdown of what compensation was given. So this was our study findings. After looking through 206 PISs, we realized that reimbursement and compensation term was used interchangeably by the investigators. Quality of information on payment in PIS was better in ISR when compared to IR. Cost for traveling was found to be the most addressed for both compensation and reimbursement, of which compensation amount varies widely from about 50 ringgit per visit to 400 ringgit per visit, while on the other hand, reimbursement amount and mode of payment varies from 10 ringgit per visit to 900 ringgit per lump sum. Right, so I think it is a persistently hot topic of debate with varying views regarding what is the appropriate payment to participants. And suitable process in determining appropriate level of payment, which addresses respect for research participants, on the other hand, attracting reasonable recruitment, while most importantly, avoiding undue inducement, was found to be lacking. So federal regulations and guidelines that is available actually provides very minimal guidance to the IECs, and we are often left with making the decision to protect the participants. And so with this minimal guidance that there is available, there is a wide variable views exist even among IECs on what constitutes appropriate payment. And of course, I think since it involves participants, what their expectations and opinions should be taken into consideration when we are determining the appropriate payment. So we've searched through literatures, although limited, but we found that many healthy volunteers consider risk as an important consideration. However, when you look at the final findings, their estimates always seems to be based on the tangible burden, which is your time and the burden or inconvenience, something which I think upon the signing of the PIS, the signing of wanting to participate in a research, that something that they can measure, right? And there is a paper that looked at the analysis of 32 organizations in US which are active in research. They actually found that participants were commonly paid for time, inconvenience, and travel, out of which only 1/3 of these 32 organizations actually had a payment guidelines. But no payment formula exists. However, there is an unwritten rules for these 32 rules of thumb in determining appropriate payment that they used. So, which brings me to this study finding is that it's similar to that reported in the literature, and that our investigators, our local investigators actually prioritize tangible burden as per participants' concern, like time and travel. Right. So what is the impact of our study? I think it provides a baseline payment trend in Malaysia in that it highlights what our local opinions of our sponsors and investigators has with regards to the reimbursement and compensation of healthy and non-healthy volunteers in Malaysia. It may also serve as a starting point for further study on appropriate payment trend, especially in obtaining local data on participants' opinion. And with this, it serves as a platform in aiding the creation of a guideline and formula, probably in the near future, for appropriate payment that can address respect for research participants, attract reasonable recruitment, while at the same time avoiding undue inducement. So we hope that this guideline, if it materializes in the future, it actually serves to help the IECs and to provide a guidance when analyzing protocols in ensuring full protection of participants, to the stakeholders like sponsors and investigators, to give them a guideline on the provision of appropriate payment, and of course to participants a full protection of interest. So in conclusion, there is a wide variability on appropriate payment, that is compensation and reimbursement, exists in Malaysia, and I think development of a standardized guideline formula on appropriate payment to research participants will be beneficial to all three parties. These are my references, and with that I thank you for your kind attention.
Interesting study. Not many have addressed the issue of compensation and reimbursement. And the other point to note is, thanks to her crisp presentation, we've caught up with time. So, with that, we move on to the last presentation slated for today regarding monitoring of the audiovisual consent process. And this will be done by Dr. Y.C. Shetty from St. J.S. Medical College, Mumbai.
Good morning, everyone, and respected chairpersons and my colleagues. The controversies in the Indian clinical trial scenario have erupted in the sense like Indian participants are used as guinea pig. There is lack of ethical oversight. Participants are recruited without proper informed consent. And this was the case where, Swasthadhikar Manch had a litigation, and Supreme Court actually gave a mandate to the DCGI office that they should monitor 5 global clinical trials in 2013 with AV consenting. To ensure compliance on the same lines, DCGI amended its regulatory notifications by bringing these guidelines of AV consenting if the population is vulnerable and if there is a new molecular entity, along with the rules for preservation and archival in 19 November 2013. There were a lot of caveats in this guideline saying that there should be a written informed consent, there should be understanding of the patient checked, the entire Schedule Y guideline of informed consent has to be ratified to the patients, and it should be preserved and archived. And another thing was there was an amendment in the same regulation by if the participant is a vulnerable population, you have to take audio consenting if the patient is suffering from leprosy or HIV. When we saw that, is there any other regulator talks about the same sense? US FDA has stated that video recording should be done in case if the participant is illiterate. ICMR guideline later, when was formulated in 2017, again reiterates the same thing which regulation talks in India is AV recording required in certain trials as required by our regulator. So the rationale for the study was, after the guideline release, there were no studies on AV consenting process. And if you see in our St. J.S. Medical College, there are at least 70 regulatory studies which come to us. And in that, at least 30% of the studies fall into this category. So we wanted to know what is the real-life situation of feasibility issues at the site, at the patient, and at the investigator challenges. Is the real consenting happening? Is the regulatory compliance of participant protection is in place? With this intent, we tried to do a retrospective analysis of monitoring reports of AV consent process undertaken by Institutional Ethics Committee. The objectives to evaluate the AV consent process was done in terms of adequacy of facility, visibility of the video, audio recording, maintenance of privacy during the conduct of AV consenting, patient and investigator communication during the consent process, time required to complete the consent process. Study was approved by Ethics Committee. It was a retrospective analysis of the documents of the Institutional Ethics Committee monitoring report of AV consent process. The duration was from October 2013 to February 2017, from which the mandate started. There was a strict confidentiality was maintained in regards to the protocol, department, principal investigators, sponsor, as well as IEC monitors. The AV consenting monitoring checklist was prepared by the investigators. At that time point, there was no checklist. There was a draft checklist which was given by DCGI office. ICD was reviewed because we wanted to know if the ICD elements have been covered in AV consenting process. And this checklist was again then reviewed vis-a-vis the ICD process by 2 authors and confirmed. And now this checklist is being introduced in our SOP, which is there in this website. The study checklist included the number of AV consents monitored each project, facility adequacy seen in the frame, video and audio clarity, number of persons seen in the video in the context of the consenting, if the patient or the investigator, as well as the impartial witness and the legally acceptable representative. Are all the elements of the ICD covered as per Schedule Y? Is the understandability of the participant seeked? Time taken to complete the procedure, whether confidentiality was maintained, and whether there was reconsenting happening if there is an amendment in the protocol or informed consent document. So the checklist had 20 questions, and there were 18 closed-ended questions and 2 open-ended questions. Now the data was entered in the MS Excel sheet. Graph-fed Instat 3.10 version was used. Demography details were analyzed by using descriptive statistics, and we tried to correlate between 2 variables by putting a test of correlation. Now, in the period October 2013 to February 2017, there were 23 pharma active studies at the KEM site, in which AV consenting was not required in 10, and there was no recruitment happening in 3 studies. So the 10 studies were flagged for monitoring. IC monitored 7 out of this because the 3 sites were the same sites. So we thought like the practices may not be differing. The 7 studies where AV consenting was reviewed were all phase 3 studies. And the specialty domain which it belonged to was chronic non-infectious uveitis, pulmonary hypertension, polycythemia, chronic diabetic ulcer, Cushing's syndrome, vaccine study, and a RH incompatibility study. So the number which is mentioned in the numerator was a number consented and monitored vis-a-vis versus the denominator is the approved number by IC. So if the total number, if you see, it's 263 patients who have been AV consented, out of which we have monitored 85 consents, which is nearby 1/3 of the proportion. And there are 5 studies where reconsenting happened, so 22 times we have seen the AV consent, reconsent as well. So the number of, so we are coming to the results. Number of AV consents reviewed were 86, in which 1 report we found missing in the IC domain. There were 22 reconsents. AV recording permission has to be taken. This is the mandate from the regulator, and which has to be seen in the frame. So it was found in 49, not found in 36. AV consenting facility and process, when we saw, facility adequacy was seen in 54 times of the cases, but it was not seen in 31% of the cases because the office, the AV consenting place was changed in and out. The same PI was taking in office, in the OPD ward, or in the OPD or in the ward, and there was a lot of noise which was heard during the process. That is what was written in the report. When you see the setup for pediatric population consenting, which was that vaccine study, which was 48 sample, in which 22 times the area was not adequate for the consenting because many of the trial participants had elder children along with them. They did not have play area, so in between they came and disturbed the investigator as well as the patient or a LAR. Child was not seen in the frame, who was the participant. LAR was seen. Multiple people in the room coming out and in, so privacy was not maintained. Camera placement and frame was not clear in 15% of the cases in the ICDs. Video clarity was there in 81% of the cases. And audio clarity, if you see, it was not clear in 22% of the cases. Here in between only the audio went off. We did not know what happened in between, and later it's restarted, but the entire ICD procedure was missing in between. Archival of the AV consent was not found to be adequate in 14 cases because we had a lot of issues. That is what was written in the report, that they could not open the video at all, and they had to consult the site for that. They had to take help of the site. Now, how was the privacy not maintained? There were a lot of intruders in the room. So the people were in the room were residents, other patients of other trials, students, MBBS students, and staff who are not at all a part of the study team. Clinical information and enquiry of the language is the starting point of any AV consent process. That is what our regulator talks about. It was not given in 81 of the 85. So what was not given is they did not introduce themselves. I feel which is because it's there, not there in our culture. The name of the PI, what is his designation, what is his role in this clinical trial was not mentioned in this number of AV consents which we are seeing. Date and time was not seen in the audiovisual consenting, because that is one of the requirements, because we can actually figure out what is the date and what is the time of consent. Identity of the videographer was not sought, because again videographer can be an independent person or he can be a part of the team. We did not know because there was no identification, nor there was an introduction to the videographer to the participants. Language comfortability you have to ask, because if the patient is a Marathi patient, you can't give a Hindi consent, but we could not make out like what the patient language is, because the PI started with whatever language he was comfortable with. The study information given to the participant, it was yes in 36 cases, but no in 49 cases. And the domains which were missing was, they were not mentioned all the risk. If there are ADRs, there are 5 ADRs, only 1 ADR was told. Compensation for study-related injury was not told in 5. Right to withdraw was not told in 3. Contact details of PI and IC, they thought it is not very important. It was totally missed in all these cases. Nominee information was missing in 20, because that is one of the things which we have to tell the patient who is the nominee, because there is a risk of death, because these were all high intensive research. And there was mismatch of information in many of the things. The ICD talks some different amount for travel allowance, and here the PI was talking something differently. Duration of therapy was, if it is 12 months, the PI said it is 2 months. There's a lot of error. Other ICD elements which were missing were consent language mismatch. We could make out by the facial expression of the patient is not understanding a word of Hindi, a Marathi patient, but the entire ICD was rattled in Hindi. Co-investigator did not ask for queries. Information on confidentiality and privacy was not given. Information on data sharing was not told. Explanation of many of the methodological concepts in the ICD was not told to the patient. Consent was given for the patient to read in 48% of the cases, but not given in 52%. Many of the PIs, they themselves read the consent, and at the end of the day, they said that you understood, and they took the signature. Ample time was given in 68% of the cases. Questions answered satisfactorily in 61% of the cases. And documentation of signature was seen in 74% of the cases. Because this is one of the regulations that documentation also has to be seen in the consent frame. The time range for signature was from 0.42 seconds to 12.18 minutes. Understanding of participants was checked in 65% of the cases, but not checked in 35% of the cases. So the duration of consent, if you see, it is 20 minutes. The range is from 10 to 30 minutes. Number of pages of the consent were 24 pages, that is median, 17 to 31 pages. And when we try to correlate between duration of consent, duration of consenting and pages, we could not, there was a weak correlation between this and there was reconsenting in time was 6 minutes, the range was 2 to 10 minutes. And in 21 cases of AV consenting, there was more than one session in the frame. Repeatedly, they were blocking, and again, they were taking reconsenting, but the patient was not ready for consenting. So they were trying to convince 2 to 7 times. Issues in reconsenting where the reason for reconsenting was not mentioned in 1. There were findings in 9 cases. Privacy was not maintained in 2. Only patient signature captured in recording was 4. Patient did not sign, which was not seen in the frame 1. Patient did not date, that was not seen in the frame also 1 again. So to summarize my findings, AV consenting facility was not as per regulation. ICD consent elements were not covered in totality as per Schedule Y. Privacy and confidentiality was not maintained during AV consent process. Understanding of participants was not checked in majority. Good finding was ample time was spent in consenting. So to discuss, we can say that AV consenting facility was not adequate. This is a peculiar problem with public health hospital where the space is an issue. And many times research is not a priority as compared to hospital or patient care. All ICD elements were not covered by the patient, nor the patient read the ICF. So these can compromise the autonomy of the patient, and the voluntariness of the participants can be a big question mark. Privacy and confidentiality was not maintained because of the wrong selection of the place for consenting. These can compromise the patient's autonomy and confidentiality. Understanding of the patients was not checked in majority, as the patients did not tuned to such things in practice. So they get included in the study, which can be due to misconceptions. It is a duty of the investigator to clear such error and check for understanding. Ample time was spent in consenting, and many of them had actually read the entire informed consent document, even being very busy physicians. These are physicians who are genuinely interested in research and follow everything in letter and spirit. Out of 10 studies eligible for AV consenting, 7 were monitored. It was a good practice of the IC even after having 495 projects annually. There are few concerns raised by authors who have not done a study, but they had their own review articles. Is it a boon or a bane if AV consenting comes in force? We think it to be a boon as it safeguards both the participants as well as the principal investigator. Ganguly and Gui had concerns regarding execution of AV consenting, but our study reports a good experience. 39% refused AV consenting was found in a feasibility study for AV consenting done in South India, in Chennai. But our study investigators stated that there was 10% refusal rate. Grady et al. Had concerns regarding feasibility in time, sessions, visibility of face, audio recording, and maintaining privacy during and after AV consenting process. We found a lot of deviation in all these aspects. There are challenges faced for AV consent monitoring as well. Denial of 2 investigators to share the AV consenting data because of the concerns regarding confidentiality. Refusal from one sponsor saying that IEC cannot review AV consent data as it is confidential, but after clarification, they handed over the AV material. Limitations of the study were, it was AV recording monitoring. So site, source documents, principal investigator and participants' interaction was missed and not confirmed. Because of the retrospective design, many of the things which we have interpreted may be existing, but we could not confirm it. We have not analyzed the reply to the findings sent to the investigator, as many of these studies have completed recruitment. Our data is not generalizable to other setups because ours is a tertiary care setup. So we want to recommend to different stakeholders, in nutshell from our own findings, For investigators to create site-specific SOPs for AV consenting, the study team to be trained in AV consent process, site facility to be made adequate, participant sensitization in AV consenting. Recommendation to the IEC is to create SOP for AV consent process, review process, regular site monitoring of the study which involves AV consenting, appropriate actions to be taken against the defaulter, and investigator education. We want to recommend the regulators as well prepare checklist for AV consenting process to investigators to maintain uniformity. Similar checklist for IECs to maintain uniformity when they're going for monitoring. Monitoring of the studies which involve AV consenting, appropriate actions to be taken against defaulter, and investigator and IEC member education in regards to AV consenting. AV consenting in a nutshell is a good thing which has come in practice, which can increase reliability, transparency, and improvement in quality of conduct of informed consent process. It can increase the society's faith in clinical research, but in a nutshell can increase the good clinical research practice. Thank you.
Thank you, Dr. Shetty, for that very clear and concise presentation on AV recording informed consent. Now the entire session, all the talks that we have had so far are open for discussion. So if we have any questions from the audience, I'm sure the speakers would be happy to respond.
Yes, so we have around, maybe we are at 11:47. I think we can go till 12:05. That's around 18 minutes. Again, please keep your questions and comments short, and please let us know which speaker you would want to respond. I think there were two broad categories in which we had sort of the presentation content. One was seemingly around the need for rejigging consent a little bit, whether at the basic operational levels or in terms of dealing with innovations, whether it's around deception, whether it's audiovisual consenting, the need for monitoring. And the second area was around sort of this whole issue of money or financial, it's compensation, whether it's payment, whether it's cash. So I think those were the two broad sort of categorized areas which we dealt with in the presentations. But again, opening up for questions, comments.
And please mention who your question is addressed to.
And introduce yourself as well.
Bibi Loth from Monash University in Australia. My question is to Dr. Gogte. Some ethicists would argue that non-authorised deception is never appropriate as research design, and I just wonder how you would respond to that.
So thank you. So your question is non-authorized deception. It's not telling them is never appropriate, right? So let me give you a clinical example. So there is a condition which is called as pseudoseizures. That's epilepsy. So pseudoseizures is you get seizures at any time. So one of the ways to test if the person has pseudoseizures is to tell them that we are giving you a drug which is going to induce seizures, and what you give them is actually normal saline, right? And the person actually gets seizures. So the thing is, where deception is a means to an end, right? And there are two approaches to it. The approach that is suggested is to tell the participant that he or she is being deceived, which is authorized deception, and that's come up about 5 or 7 years back, right? So the important thing is to check which modality of deception really helps. Is it non-authorized deception? Is it authorized deception? And generate more evidence on both these modalities of deception in the form of randomized controlled trials. Yes.
The same from the same speaker. The results of your study showed that people who were told that they were taking expensive drugs had to have rescue medications, correct? More than the inexpensive drug. And, I was thinking about this, and you said maybe it's the expectation. And can you presume that the expectation is that because they are receiving expensive drug, that they should not feel any pain, and therefore there's need for them to complain later on and to have some rescue medication as compared to the one that is receiving inexpensive, and therefore the expectation is not too much? so that there's no need for rescue medication? I mean, I would like some of your insights and your explanation related to the different results.
So the reason why we chose cost as a modality of deception is because there are studies in literature which have actually compared generic, that is the inexpensive medication, versus expensive medication. And this concept is done in the developed countries. And the perception is that the generic medication, or the less expensive medication, is actually less efficacious and less of quality. So that is the perception in the developed world, which is why we chose this particular model, right? And the studies in the developed world have actually shown that when they are debriefed, they said, oh my God, so you're actually getting, the same medication. So cost does impact perception. Now coming to our study, which was done in a developing country, we had two groups. So we had the authorized and the non-authorized. So if you looked at the non-authorized, they were not deceived, there was no difference. So it didn't matter whether you got an expensive or expensive, the extent of rescue medication was pretty similar. Now, if you come to the authorized deception, look, I am deceiving you, that group. The number of people who got the so-called inexpensive medication was just 12%, whereas 31% who got expensive medication took the rescue medication. So our hypothesis is that when you tell people you're deceiving them, and the group happens to be expensive medication, we wonder if they thought that they were actually getting the inexpensive medication. You tell them you're getting expensive, the envelope says expensive. You also telling them that you're cheating them in some way. So I wonder if whether they perceived the expensive to be the inexpensive as the modality of cheating or deceiving, leading to a higher use of rescue medication in that particular group. And therefore, coming to whether authorization, telling them about deception, is actually in some way impacting expectancy. So ma'am, to add to your question earlier, there are ethicists who say you shouldn't be using authorized deception at all because it defeats the core of, patient care. So yeah, that's, I hope that answers your question. Yeah. Yes, sir.
Thank you, sir. I am Arvind from AIIMS Bhubaneswar. My question is to Dr. Shetty, the last presentation. Madam, most of the clinical trials which are done, the place of consenting and the study procedures are the same facility, that is the hospital. I was a part of one of the vaccine trial where we did the consenting in the village, in the community, taking all the precautions about privacy and all these things. And the actual study procedures or the vaccination and other recruitment procedures were done in the hospital. What we observed there, that participant used to give consent over the camera, but when they come out, they discussed with their relatives, and they always had a rethought over the process which they have consented to inside. And most of them consented out after giving the AV consenting. And that was a very tricky situation for us. And so, of course, we did not went ahead with recruiting them. Is there any literature available which has explored this aspect?
Yeah, actually, we also have a dilemma in this because there is no regulation clear. There is no regulation clear about this. Like the people who are actually not consenting in the frame, can they consent outside the frame? So that is what I have written in my limitations, because we could not make out, because we are not seen, we are not interacted outside the frame. What we have seen is captured is only inside the frame. So we thought like if AV consenting is not asked inside the frame, means it is not asked. But maybe that investigator has taken AV consenting and signature before that, because that is ignorance of the investigator, because there are no guidelines. So, this is all, set up. So that is what we've written into the limitations. But there are no guidelines for that. So when a mandate comes as AV consenting, everything has to be in frame. So AV consent permission also should be in the frame. That is what is the perception of investigators. Again, regulators are not clear about this. So it is a mandate only in India. So, we don't have any other studies to collate or any other regulator to talk about. But US FDA also, when we saw into the US FDA illiterate this thing, they said their consenting should be in the frame. That is
they consented in the frame, but when they came out of the frame, they consented out. They told that I am not going to participate after giving a rethought, because if they are on the camera, they are a little bit threatened and that frightened. And that was we conduct a lot of clinical trials, and that was the first clinical trial which had this AV consenting procedure. So they were very much kind of skeptical that what this new thing has come up. So they used to consent it, but when they came out of the room, they told that, "No, I don't want to participate."
I think so. That can simulate that study which we saw in South. That was a feasibility study for AV consenting. So I went into the population and asked people like, "Are you ready to do AV consenting?" So the proportion of AV consent refusal was more than 40%. So that is what I mean. Like, that is what is simulating the situation. In our case, it was good enough because I don't know, our investigators have convinced the patient well. So they have, in that frame also, they have accepted for consenting. We don't have that data outside, but there was no refusal. Because we have retrospectively it was interviewed the investigators, they said AV consent refusals were less as compared to the study which we have quoted.
Thank you, ma'am.
Thank you.
There.
This is addressed to Dr. Nitya. I'm Saumil from CMC Villa. I got two questions. One is for the science part of it.
Yes, sir.
And the other is on the ethics part of it.
Yes, sir.
With respect to the science part of it, you mentioned about it being an equivalence.
Yes.
The fact that you didn't see any difference between the two groups, I was thinking the inference of scientific inference from equivalence trials is with respect to the two one-sided tests that we have, minus delta versus plus delta. So whether that would have been a better result to be inferred from, because essentially no difference doesn't mean much in case of equivalence trials. So that's one. With respect to use of deception, I work with psychiatry and social and behavioral science. We use largely restricted to sexual science and research. It is very difficult to explain deception to people. You had only one person refusing to take part in the trial. I would be interested to know what made him refuse and him or her refuse. If the refusal rates are higher, it actually means that the trial is well done and that the deception is well explained to the individual. That might be a proxy indicator of how well the trial is done. Thank you for the...
Yeah, let me answer your second question first. You are talking about consent refusals as a metric of the quality of the trial, if I have understood you correctly. So the reason why that particular person declined consent was that he felt that he would be randomized to the inexpensive arm, right? He also fell into the non-authorized deception group. So if he would have been randomized, so he didn't want to take a low quality in his mind, or perception was that he didn't want to take a low quality painkiller, and then he opted out of the study. One of the major concerns that we had when we did the study was that these are patients in pain, right? They have third molar extraction, they're worried about surgery, and you're going to do a trial on deception. If you look at literature in general on deception, there are very few studies which have been done in patients, and psychiatry patients would be the furthest away in terms of using studies on deception. So that's another aspect altogether. The large number of studies in deception have been done in normal, healthy volunteers, or it has been done in situations of cannabis addiction or alcohol addiction. So essentially the person is normal, healthy. The one other study which I can think of has been done in patients with mild Parkinson's disease, where they were deceived about getting levodopa or otherwise. So the context of these studies is largely normal, healthy volunteers, and so psychiatry would be, I think, further removed. Now, coming back to the third molar extraction, when we discussed with our dental colleague about this deception study, in fact, what she said is, please don't do it before the surgery. Before the surgery, the patient would be in a lot of pain, and he would be worried whether the surgery was going to be a deception, the surgery itself. So we did it at a point when the surgery had been completed, the patients were still under local anesthesia, and they usually wait for an hour and a half in the dental clinic before they are sent home, because you're watching for anaphylaxis. And the location was, it was a quiet place, and the patients took almost between 25 minutes to 45 minutes to give consent for the study. So I would say the quality and the adequacy of the consent process was in place, yeah, except for the one consent decline. So I would beg to differ in terms of that being a metric of the quality. Going back to the TOST test, which you talked about, that is the two one-sided tests, the equivalence margin was 1, and that equivalence margin was met. So the null hypothesis was that there was no equivalence, while the alternative hypothesis was that there was equivalence. So we did reject the null hypothesis. Although the presentation focused on the VAS score, we did meet the equivalence margin that we set out to begin with. Yeah.
I have a question for Dr. Ching Shan. Yeah. First of all, I would like to congratulate you for a good study and a very good paper on an area which is not much research and there are no guidelines. Our team at KM Hospital, Dr. Thatte, myself, Dr. Shetty, we have done this study a couple of years back and the paper is accepted for publication. Our findings were similar. And it's a big question mark as to how we should go about deciding the payment as a local policy also. So my question is, how have you decided the payment based on the risk, because you have taken high risk? I understand for travel and time, travel there is a direct calculation that amount spent for travel, but for time spent and the risk involved, what is the method that you use to quantify the amount? That is one question. And second question is whether the payment differs from academic studies versus pharma studies, because in our study that was one finding that investigator initiated academic study, the quantum is less. So these are the two questions.
Okay. So just want to repeat the question. So
the first question was time and risk. How do you decide payment? Do you have any kind of
actually this study was, we want to have a look to see what was actually the trend without zooming into what was supposed to be addressed. So that was the baseline of what we actually wanted to see, what is actually happening at our local data.
Yeah, I understand that, but I'm asking as an ethics committee, you are an ethics committee member, right? So what is the method that you use to decide payment based on time spent, or for healthy volunteers, for example, in the high-risk studies? I'm asking that
for the future, for the coming one.
Time being also, how do you decide and how do you approve the payment?
Oh, okay.
Not decide, approve.
Yeah, so I think the problem, this was actually the reason why we actually came about to this study, right? So I think to answer your question, we looked at the tangible burden. So when we discuss, we would try to see like, okay, if let's say this study is involving this subset of patients, we'll try to kind of like use our own judgment, you know, like currently now, how much would it cost to travel from here to here and things like that, without taking risk into consideration.
Okay, so it's only based on travel.
Yes, just the inconvenience and what the patient, because if you look at like what I presented just now, assumes actually your compensation and your reimbursement should not be based on the risk that's involved in the study. It should be actually based on the patient, the subject, the participants should not be expected to pay further because they are already contributing to the you know, the science.
But they are spending time. There's loss of wages. And
so may I please request you to have this dialogue over lunch? I will have one last comment, Dr.
Sorry.
Juntra, you had raised your hand for a question. A last question. After this, we break, and multiple discussions can take on over lunch.
It's not exactly the questions, but it's more or less comments on this issue. I think it would be very hard to find some formulation because different culture, different distance at least. Okay, you cannot really calculate from that. But the burden that you are talking about has to be defined because burden on what? You know, you have to be restricted from eating something for the whole day, which you usually take. So that you have to put that into consideration. I think the payment issue, it has to really rely on the ethics committee because it's a local, you know the culture, you know how much, blah, blah, blah. So I think it would be very difficult to find out a formulation universally. So the burden and the time is also including in the burden. Okay, like if you put the halter, you cannot take shower and that person take a shower twice a day. That is a lot of burden, right? So that's the ethics committee have to think about all those things rather than, think about the risk. But when we talk about compensation, you might have to talk about compensation to injury. Okay? Instead of just compensation, then people get confused, what are we talking about? So the payment of your inconvenience and all sort of things, that's one issue. The compensation for injury, that's another issue. If you talk about the high risk type of study, so the phase 1 study would be very high risk, right? So the compensation to injury would be much higher when you do the insurance. The premium will have to be higher, something like that. So I think the ethics committee members have to sort of think in that line of...
I think this compensation that we're talking about is more towards compensation of like your time span, your participation and stuff like that. Actually, we did there is another study which my colleague is presenting over the other hall. He is talking about compensation on injury and post-trial access and things like that. So, I get what you're trying to say, Prof. I get what you're trying to say,
I just want the ethics committee to think of along this line. You don't get confused yourself. And when we are talking about the burden, you have to also consider the normal things that have to go through. You don't just say, okay, they have to go to 13 investigation. But normally, in their daily disease, they already have 13. So that's not the extra burden. It's about the extra burden for that research that you have to think about. Thank you.
Thank you for your comment.
Thank you, Dr. Lauthavant. I think considerable discussion following 5 wonderful presentations with a wide variety of aspects regarding informed consent. I do get an impression at times that we need to consent the speakers before we expect them to answer, because some of the questions are so long that we are not very, very sure if the speakers have understood the questions before they embark upon answering. With that little comment, I think we'll close this session. A round of applause for all the speakers and the discussion that followed. And I think everybody's got a good appetite now for lunch. Bon appétit. Merci. Thank you so much.
We thank our chairpersons for such a elucidative and informative session, and the speakers as well. We are breaking for lunch. We'll be getting back at 1 p.m. and the poster session will also be held along the lunch hour.